Bismillah ar-Rahman ar-Rahim. My colleague today, I am going to talk about outpatient management of pediatric asthma. As all of us knows that asthma is the most common chronic illness threatening the life of the patients in pediatric age group. So to make more focus on this disease, today I am going to talk about its control. Asthma is a chronic inflammatory disorder associated with variable airflow obstruction and bronchial hyperresponsiveness. It's characterized by recurrent attacks of wheeze, cough, shortness of breath, and chest tightness. Regarding the epidemiology of asthma, as I said, it's the commonest chronic illness. By the way, allergic rhinitis is more common, but allergic rhinitis is considered as a disease which do not threatening the life of the patient. In Saudi Arabia, the prevalence has been raised from 8% at 1986 till it reached 23% on 1999 in school children. In different cities, Professor Al-Freh make this study. We can see this one in 2007 that it's in Riyadh 10%, in Dammam 12%, in Jizan the most common area which is 24%, and in Jeddah 12%. In Europe, the highest country is United Kingdom. It's more than 20% of the kids they have asthma. Also in Romania, it's more common. The second countries, which is between 10 to 20%, is Spain, Portugal, and Belgium, and so on. Italy also. This will make a strong impact on the daily life of the children. So 64% having a missed school, 52% limitation of sleep, 80% have emergency room visit, 53% having a limitation of normal physical exertion. Now asthma considered as a syndrome rather than a disease. As we know before, it was considered as a psychosomatic disorders until the 60s when they start they understand the mild pathophysiology of the illness as inflammation or as a bronchospasm. Then after that, in 90s, the cytokines rule has a more focus, and now they consider it as a syndrome with a different phenotypes caused by a different endotype or a different pathophysiology. Now they classify the phenotypes either according to the age of onset. So we can see in this figure that asthma could be classified as a transient early wheezers, those who are having recurrent attack of wheeze, usually because of the viral infection, and then after the age of 3 years it's gradually resolved. And there are two other persistent wheezers, one of them called IgE mediated wheeze, which is the classical asthma, and the non-atopic wheezers, which is other form, and usually they are not IgE mediated asthma. Also, we can classify the phenotypes according to the disease severity, because those who are having severe asthma usually having a more focus and more concentration, because they are the one who are having frequent hospitalization, PICU admission, and so on. So they are usually having, for example, high fractional excretion of exhaled nitric oxide, and obese children is also associated with severe asthma. And the new phenotype, which is recently discovered, the new severe phenotype, which are obese girls with early menarche. So those who obese girls with early menarche usually having the most severe form of asthma. Also, we can classify it according to triggers, as a viral-induced, exercise-induced, atopy-induced, or a multi-trigger, or unresolved, sorry. Also, another phenotypes could be classified according to the treatment responding. So those who are steroid responders, their phenotype usually they are having eosinophilia, high IgE, having associated atopic dermatitis, and so on. So as we said, asthma is there are many phenotypes. There are many phenotypes caused by different endotypes. Also, they discover that the inflammatory features, it could be either eosinophilic or a neutrophilic. The eosinophilic is the classical, as I said, classical asthma is eosinophilic with high IgE, but neutrophilic inflammation is documented in, discovered even in pediatrics. Before it was only described in adults, now also in pediatrics. This is the pathophysiology of a classical asthma. When there is an allergen enter to our body, catch by the antigen presenting cells, and then the antigen presenting cells to Th2 cells produce interleukin 4, lead to IgE specific production against this antigen by the plasma cells, sensitization of the mast cells, and then after sensitization of the mast cell, the second exposure, the second entrance of the allergen lead to degranulation and release of the mediators, it's histamine, leukotrienes, and cytokines, and the initial response with vasodilation, vascular leakage, and smooth muscle contraction. On the other hand, the Th2 produce interleukin 3, 5, and GM-CSF, lead to eosinophil recruitment, and then activation and release of leukotrienes, interleukin 3, 5, and 13. This lead to late phase reaction. Now we come to viral-induced disease, or what's going on in viral-induced disease. The pathophysiology is completely different, as we can see in this figure. When there is, for example, in normal child, there is a viral infection, there is increased interferon gamma and strong natural killer cells and Th1 response, upregulation of the interferon stimulated genes. These lead to robust antiviral responses and minimal inflammatory response and complete recovery. While in asthmatic, during the viral infection, there is impaired interferon response and predominant Th2 cells and low interferon gamma. So now let's consider those with viral-induced disease or viral-induced asthma have a mild, or let's say some problem or impaired immunity. Yes, they have impaired immunity because viral infection causing more exacerbation, more severe infection in them. So as I said, this leads to uncontrolled viral replication and cell necrosis, excessive inflammatory response, and lead to exacerbation. Here we can say when there is a viral infection and irritation of the epithelium, these lead to sensory nerve, before there is a more secretion of the neuropeptides with a smooth muscle contraction, and sensory nerve stimulated the parasympathetic nerve. These lead to acetylcholine production. Acetylcholine causing smooth muscle contraction. In normal situation, the acetylcholine production lead to negative feedback through the M2 receptor, so there is no more acetylcholine production. But because of the viral infection and inflammatory mediators, the autoinhibitory feedback is stopped, so there will be more acetylcholine production and more bronchospasm. Even, let's see if for the other phenotypes, for example, in the exercise-induced disease, the pathophysiology is again different. There are many theories, either the dry air theory, cold air theories, and irritation of the airway by the dried air and dried mucosa, and so on. For the obesity-related asthma phenotype, also the pathophysiology is completely different. There are many theories about the obesity-related asthma phenotypes. So in summary, the asthma is a syndrome. Let's agree about this concept, which is highly focused nowadays. It's a syndrome rather than a single disease. Now, let's understand what is IgE and role in allergy. What is atopy? Atopy, when we say atopy, is a genetic predilection to produce a specific IgE following exposure to allergy. What is sensitization? It means someone predisposed, exposed to the allergen, and then produced IgE, but not yet exposed for the second time and not yet having a sign and symptoms of allergy. Allergy, individuals who are sensitized, they have specific IgE and expose and develop the symptoms of allergy. Simply in this study we can see what is the difference. In the United States, between 2005 and 6, they screened 8,000 individuals for the 19 common inhalants allergy. They found that from those 8,000, 44% had specific IgE antibody to at least one allergen, and 34% had symptoms suggestive of allergy. So those sensitization and those are the allergy. This is the difference. And don't forget that the IgE could be elevated by many other causes like infectious disease, immunodeficiency, inflammatory disease, neoplasms, and others. It's not only because of allergy. And even those with a normal serum IgE could still have local production of allergen-specific IgE in the tissue. So if it's normal, it doesn't mean that this patient is not allergic. We try to rule out the comorbidities of asthma, which should be treated whenever we have asthma, like rhinitis, rhinosinusitis, polyposis, obesity, obstructive sleep apnea, GERD, psychological stress and anxiety, dysfunctional breathing, I will come to highlight it in the next slide, and exercise-induced laryngeal obstruction. Now, what's dysfunctional breathing? It's frequently a breathless patient have often learned a maladaptive breathing strategy causing or perceived as dyspnea. Okay, so some patient having, for example, on and off deep sigh, taking a deep breath, or forceful expiration, or forceful abdominal expiration, or thoraco-abdominal asynchrony. So many other different forms. This could be interpreted wrongly as a dyspnea rather than it's called dysfunctional breathing. If we discover that, we first avoid the abuse of the medication and then open a new path for the non-medical treatment, which is by a speech therapist or the physiotherapist. In this study in 2013, they found that asthmatic patients referred to tertiary center because of severe asthma, 5% of them having dysfunctional breathing. 5% of them. So if we discover this 5%, it's important because at least those 5% will be managed in a different way. The classical form of the dysfunctional breathing is what's called exercise-induced laryngeal obstruction. Those usually, it's similar. The patient coming complaining of dyspnea during exercise. Dyspnea during exercise. It's relatively easy to identify because usually the patient showing the signs here on his neck usually tell you that I cannot take a breath. I feel that there's obstruction or a block here in my neck, and I cannot get enough air. And usually he's clutching his neck during speech. Sometimes some words, he may have stuttering, or he may have some few words he cannot produce well because of the laryngeal obstruction. As I said, we should differentiate it from the viral-induced asthma, exercise-induced asthma, and this could be managed with a non-pharmacological management. Always concentrate also before considering the patient is asthmatic for the symptoms which are against asthma, like for example failure to thrive, finger clubbing, chronic productive cough associated with failure to thrive, associated with other things against asthma, or could be associated with asthma. Then let's come to the diagnosis. Usually the features are typical, mostly diagnosed from the history. Cough, usually a dry cough in the night, early morning, with exercise. Sometimes they hear a wheeze, difficulty in breathing, or the patient may feel like a chest pain because of the chest tightness. And usually there is a family history of asthma or atopy, and usually also there is a trial before of anti-asthma medication like ICS, and there is a good response during that period. These features help us in the history. And concentrate in the physical examination on the skin to see the to look for atopic dermatitis, to look for the signs of allergic rhinitis. This helps you in the diagnosis, because usually the patient having associated either allergic rhinitis or atopic dermatitis. Also look on the chest. You will find could probably increased AP diameter. There could be having a Harrison sulcus. By auscultation there is expiratory wheeze, and coarse crackles could be here sometimes. Usually we don't need to do investigation, but at least we should know that investigation sometimes could help in differentiating between asthma and other disease, like fraction of exhaled nitric oxide. X-ray, we should do it initially upon seeing the patient the first time, and we should rule out any anomalies or any infection sometimes, but with a frequent visit, no need to do it unless the patient in status asthmaticus or you suspect that there is infection. Allergy testing, it could identify allergic factors, and it may help in the prevention strategy of the allergy. For the pulmonary function, we may find variable airflow obstruction of 20% or more with serial spirometry or peak expiratory flow. And we may find improved in the FEV1 of 12% or more after bronchodilator therapy. We cannot do it, not even before 6 years, and even sometimes 8 years child have difficulties of doing it, especially the spirometry. I'm talking about spirometry because it needs to do a prolonged expiration for more than 5 or 6 seconds. This is the peak flow meter. It needs a cooperative child to do it, a forced expiration, and we may check the normal value according to the height of the patient, and decided whether it's more than 80% of the predicted for height, 50 to 80% yellow zone, and less than 50, which means that there is exacerbation. Okay. Now, what is helpful here in the prediction of the recurrent wheeze in later childhood? Because this is the most common question asked by the mother. Do my child continue to wheeze or not? Or is my child continue to have asthma? So if the age of the presentation, the earlier the age, the better the prognosis. So in a cohort, they found that a break point of 2 years, most children who present before this age become asymptomatic by mid-childhood. But if the patient having a risk factor of wheeze, this is independent of the age of presentation. I mean, if the patient having family history, if he having atopic dermatitis, even if he started early, he is going to continue to wheeze. For the sex, male more common in prepubertal asthma. Female usually continue from prepubertal to adolescent, and usually the male outgrow the asthma, not usually, more likely to outgrow the asthma from puberty to adolescent. For those who are having severe and frequency of wheeze in childhood are associated with recurrent wheeze that persist into adolescence. So whenever it's more severe and more frequent, they are usually more commonly having recurrent wheeze in adolescence. For the coexistence of atopic disease, if there is a history of atopic condition or IgE positive to wheat, egg white, or inherent allergen, this predicts later childhood wheeze, asthma. And positive skin prick test for aeroallergen or raised blood eosinophil count, this related to severity of current asthma and persistent through childhood. Family history, as I said, is the most important, and the strongest association is maternal atopy for the persistent through childhood. Now let's come to the asthma predictive index. This helps us in answering many of the questions of the mother. So if the child is having more than 4 attacks, one of them witnessed by the doctors, and having 1 major or 2 minor criteria, at the age more than 3 years, having 4 to 10-fold increased for the risk of asthma. If this is negative, it means he is having 95% chance of outgrow their asthma later in life. The major criteria is parental history of asthma, skin positive for aeroallergen, eczema, and the minor is eosinophilia more than 4, wheezing unrelated to cold, and allergic sensitization to milk, eggs, or peanuts. Let's come to the management. First, we should know what is primary prophylaxis, what is secondary prophylaxis. Primary prophylaxis before the start of the illness. So the mother will keep asking maybe question, I don't want my second child to have asthma, what shall I do to prevent my child from getting asthma? So she may start telling you, I want to prevent him from exposure to aeroallergen. From now, he's in the first day of life, I will try as much as I can to avoid aeroallergen, but you should tell her no benefit from doing that, and no benefit from any food you are taking during pregnancy or lactation. The only thing you advise, breastfeeding. No need to modify infant milk formula, no need to modify weaning, no need to supply with the fish oil, no need to give probiotic. Tobacco smoke should be avoided, tobacco smoke exposure is very important. And immunization, because there was a lot of talk that immunization could cause asthma. There is no evidence behind that, so immunization should carry on without any delay. So now only prevention of the tobacco smoke exposure and give breastfeeding. This is the only 2 advice. The secondary prophylaxis after the asthma started. In this Cochrane review of 55 trials, including chemical measures, physical measures, ventilation, freezing, washing, air filtration, all these measures against the house dust mite avoidance. It shows that there is no evidence and no benefits. Whatever they do, there is no benefit. So the British guidelines in the management of asthma, they put an evidence-based aid that physical and chemical methods of reducing house dust mite levels in the home is useless. So please don't waste your time, don't waste your money in the secondary prophylaxis. But always there's some hope. There is a new device. We hope there will be a more, let's say, trials on this device is called temperature controlled laminar airflow device. This device is applied over the child during sleep. It can be employed over the bed in a domestic environment and can result in a massive reductions in allergen particulate exposure. So in this, there is a study done for this patient for 2 months in 282 individuals and age between 7 and 80 years. It found those they having usually house dust mite allergy, cat and dog allergy. They show significant improvement in asthma-specific quality of life and significant decrease in the fractional exhaled nitric oxide. Also in this other study, in the post-hoc analysis, they found that those who are taking stage 4 GINA guideline therapy having significant improvement of symptoms during sleep while using this device. Again, to secondary non-pharmacological prevention, smoke avoidance at home is very important. For the other allergens like animals, the removal of the pets from home having paradoxical results. It's not yet proved that if you remove the pets, you will have improvement, even for the cockroach. So keep the cockroach at home. No need to remove it. Okay. Dietary manipulation. There is a lot of talk about sodium intake. There is no benefit from salt reduction. Although magnesium is used now, magnesium sulfate, to treat asthmatic attack, but it's not approved that increasing the magnesium sulfate could help. Also, fish oil, there is many studies giving very promisable, but not yet proved that it is beneficial. The dietary antioxidants also no benefit. Weight reduction is very important. Weight reduction is very important as evidence B. Probiotic no benefits. Then we'll come to the initial management. Before starting initial treatment, first you do assessment. What's the control state of the patient? Assess the patient for the risk factors and obtaining the what's called childhood control asthma test or the track score if he is below 5 years, and then start teaching the patient on the inhaler technique and the asthma action plan. And before that, be sure that you are following the patient. If you are not following the patient and you will lose everything. You will lose the patient, you will lose his control, the patient will lose the teaching, and then even he will lose his money because he's paying for the visits and medication. Because without follow-up, the asthmatic patient will not be controlled. This is the level of the control, is either controlled, partly controlled, or uncontrolled. And there are four criteria: daytime symptoms, limitation of activities, nocturnal symptoms, and need of bronchodilator. Those who are controlled usually having less than 2 attacks per week, or less than 2 per week's need for the bronchodilators. Okay? Those who are partly controlled having more than 2 of the following, either more than 2 days per week of daytime symptoms or any limitation of activities and so on. For the uncontrolled, they have 3 to 4 of that criteria. Then you should be sure that the patient, is he have any risk in the future, like the risk of the asthma attack, if he have, for example, uncontrolled symptoms during the last few months, if you have one or more severe asthma attacks, as I said, or the start of the usual flare-up season, or exposure to tobacco, or if you have a fixed airflow limitation, like patient with a severe asthma with several hospitalization or a history of bronchiolitis not improving. Also, check for the medication side effect. If the patient having frequent courses of steroid, or he's having very high dose of inhaled corticosteroid with incorrect inhaler technique, for example, exposure of the eye. Some patients using nebulization with a very big mask, or they use a very big mask from the meter dose inhaler. They are exposed to have a side effect of the from the inhaler steroid. This is what's called TRAC, the respiratory and asthma control test, below 5 years. This is very important tool for the control. We can follow the patient in the OPD. And this is called childhood asthma control test. This is also a questionnaire for those who are 4 to 12 years of age. How we choose the inhaler device below 5 years? You use the pressures MDI with a spacer with face mask. This is a preferred device. The alternative is a nebulizer. 4 to 6 years, pressure MDI with a spacer with mouthpiece. Use with a mouthpiece, the blue one. Don't use the mask. Use a mouthpiece. More than 6 years, you will use a dry powder inhaler, either discus or the turbohaler. This is the preferred now. Or you use a breath-actuated pressures MDI. The breath-actuated pressures MDI is this one, similar to any inhaler, but you don't need to press on it. It's only inhaled, and this will give you a puff. The device will help the patient in taking the inhalation. Or you can use, if the patient cannot use all these or it's not available, pressures MDI with a spacer with a mouthpiece. This is asthma action plan. We should educate our patient how to use it. Contain 3 zone, green, yellow, and red, and the level of the control with the medication he is taking, and what action shall he do whenever he have exacerbation and he became in the yellow zone, what symptoms he have, and what medication he should take, what action he should do at home. This is what's called self-management. It should be encouraged. Now for the pharmacological therapy, we have many medications. The most common one is the inhaled corticosteroid. This having many effect on the inflammatory cells and for the structural cells. It's the cornerstone in the management of asthma. It's have a very important effect on the number of eosinophils, lymphocytes, will decrease the cytokines, the mast cells number, the macrophage will decrease the production of cytokines and decrease the dendritic numbers. For the structural cells, the most important effect is the increase the beta-2 receptors. So improve the effect of the short-acting beta agonist inhaler. This is here in this table we can see that the inhaled corticosteroid, we have 3 doses, low, medium, and high dose, and always try to use the lowest dose. So you prevent the long-term side effect to the patient, like, for example, short stature or stuttering of the growth because of the inhaled corticosteroid, adrenal suppression, and so on. The second controller is anti-leukotrienes. As we know that the cystinoid leukotrienes is very important mediators. It could affect the airways by inflammatory cells, increase the mast cells and eosinophils. On the blood vessels, it's causing leakage and edema. On the airway epithelium, it increases mucus secretion, decrease mucus transport, and also increased release of tachykinins and also eosinophil recruitment and the smooth muscle contraction. So whenever we use a combination between anti-leukotrienes and steroid, we can, because some effect which can not be done by the steroid is the cystinoid leukotrienes. The steroid will not work on the leukotrienes. Okay, so if we combine, for example, steroid and leukotrienes, This will make the airway of asthmatic is better because of this effect. The LABA, long-acting beta agonist, and inhaled corticosteroid having a synergistic effect, as we said here, in that budesonide and formoterol. The budesonide increase the glucocorticoid, the formoterol increase the glucocorticoid receptors, and the budesonide increase the expression of the beta-2 agonist receptors, so both of them augmented the effect of the others. We will see in the stepwise approach that the short-acting beta agonists are mentioned as the first step, but be careful about short-acting beta agonists. It should not be overused, it should not be followed, because it's causing tachyphylaxis, rapid receptors tolerance, rebound bronchoconstriction, reduced response to short-acting beta agonists, increased inflammation and response to allergy. So always check how many meter dose inhaler used during the last month. If he told you I finished 1 or 2, means he's overusing it, and try to add another medications controller to avoid these side effects. The new long-acting muscarinic antagonist, it's called tritropium bromide monohydrate. We are using the anticholinergic. The first one is atropine. It was used for asthma before, and then the ipratropium bromide, which is the Atrovent. We are using it. Okay, but those are Atrovent used for a reliever of the asthmatic attacks. But the first controller, long-acting antimuscarinic, is a tritropium bromide. Now it's approved since February 2017 to be used in pediatric more than 6 years of age, but till now it's not approved. It is not mentioned in the GINA guideline or the CINA guideline. For the allergen-specific immunotherapy in pediatrics, okay, it's not indicated. So whenever a talk or anyone asks you, I want to use immunotherapy for sublingual or subcutaneous, GINA guideline and the British Thoracic Society guideline do not recommend allergen-specific immunotherapy for the treatment of asthma in children. In adult it's mentioned, but in children is not mentioned. The story of vitamin D is long. For the non-biochemical effect of the vitamin D, they found that lower vitamin D in children are associated with worse asthma control, lung function, and increased risk of exacerbations. And they found that negative relationship between airway smooth muscle mass and serum vitamin D level in children with severe asthma. In this meta-analysis, in people with predominantly mild to moderate asthma, they suggest that vitamin D is likely to reduce both the risk of severe asthma exacerbation and healthcare utilization. There is, for macrolides also there is a lot of talk, but it's not recommended and its role is not present to treat asthma in children. For the monoclonal antibodies, omalizumab, it's approved for the stage 5, and above the age of 6 years. It could be used for those who are having severe asthma and those who are having high IgE, more than 20 international units per liter. And this should be given by the either allergist or a highly expert person in treating asthma. This is the stepwise approach. Now we evaluate the patient and we decided to start the treatment. Those who are controlled, I mean they are using short-acting beta agonist in less than 2 times per week or 2 times per week. They're having mild symptoms 2 times per week. They can use short-acting beta agonists. But those who are having frequent symptoms, so you should either you start by step 2 or 3. Step 2 is low-dose inhaled corticosteroid or leukotriene modifier. Step 3, either double-dose inhaled corticosteroid or low-dose inhaled corticosteroid with leukotrienes modifier. Step 4, you will use
high dose double dose inhaled corticosteroid with leukotrienes modifier, and this level you should refer to specialists in asthma management. And then step 5, you should consider oral corticosteroid. For those who are 5 to 12 years of age, the difference in the step 3, you can consider low dose inhaled corticosteroid with LABA or medium dose inhaled corticosteroid. For the step 4, medium to high dose inhaled corticosteroid with LABA plus minus leukotrienes modifier. Step 5, we may consider systemic corticosteroid. Now, adjustment of the therapy every 1 to 3 months. When you follow the patient, you can adjust. It's not necessarily you step down. You may step down or not according to the patient. If the patient season, for example, enter to the season of flare-up end, you can step down. If not, you can continue. And it depends always on the control asthma test or the tract score and your physical assessment or pulmonary function test. Okay, what's new in the GINA guideline up to date? That the encouragement of the self-monitoring at home and use of peak flow at home, and the written asthma action plan to be used at home. And they also suggest to treat with a low-dose inhaled corticosteroid, even with infrequent symptoms, to reduce the risk of exacerbation. For the monitoring of asthma, there are a lot of biomarkers for asthma monitoring, but I found it, and even in the GINA guidelines and SINA guidelines, it's usually not indicated. So let's follow what's called primary care monitoring. This is very valuable, and we can follow in our clinics like the symptom score, as I said, the childhood asthma control test, and asthma questionnaire, and asthma attacks. You should ask about it, how frequently use of oral steroid, and the inhaler technique should be checked every time, and adherence to the medication you check the refill of the medication, and also check for the possession of and use of self-management plan, or what's called asthma action plan. Again, ask for the tobacco smoke exposure, and check for the height and weight, at least 1 yearly. This should be done whenever the patient coming to your clinic at least every year, but you can check it every 3 to 6 months when you follow the patient. And thank you very much for your listening.